Welcome, everybody, to the online event by the International Diabetes Federation, Understanding the Global Impact of Diabetes to Drive Policy. My name is Paraskevis Alpea, and I am the IDF Epidemiology Manager. I will be happy to moderate today's online event. Welcome from IDF. This webinar will be recorded. You can activate Zoom-generated subtitles for this webinar by clicking on the closed caption button at the bottom of your Zoom window. Please note these subtitles are not 100% accurate. The recording, slides, and feedback questionnaire will be sent to all registrants in a few days. Participants who attend at least 80% of this event live will receive an attendance certificate only if they complete the feedback questionnaire. Please check your spam folders if you have not received them by July 16. Please use the Q&A function to post your questions to speakers and panelists. We will start with a recorded message from the IDF President, Professor Peter Schwartz from Germany.
Dear Chairman, it's a great honor to speak here today to you. I'm Peter Schwartz. I'm Professor for Prevention and Care of Diabetes, and I'm the President of the International Diabetes Federation. It's a great honor to open this webinar, Understanding the Global Impact of Diabetes to Drive Policy. And actually, I must say the title says everything. We have to understand what is the global impact of the current numbers of people living with diabetes, how is a projection for the future, and we have to translate this into improved policies to improve the quality of care for people living with diabetes. And it's a great honor a few weeks ago that I had the chance at the IDF World Congress in Bangkok to release the 11th edition of the Diabetes Atlas. And this showed that we talked today about 589 million people living with diabetes in the year of 2024, and it will rise to, in the next 25 years, to 853 million people with diabetes. And this calls for an urgent action. This number is far too high, and we have to act to bring this number down. We have to act to tackle the roots why the people develop diabetes. We have to act to better understand determinants for the development of diabetes and translate this into policy. So it's, let me say it, it's very cool that you participate in this webinar and dive into it to understand the global impact of diabetes. And don't stop there. Think about how we can use this understanding to drive policy, to encourage policy development. Every little step to improve the quality of care for people living with diabetes is a good step. And maybe in your environment, you can do small steps. Maybe you can encourage bigger steps. Maybe you can work with the Ministry of Health to go big steps in your country. So I would like to thank you for your enthusiasm, your energy, your commitment, your passion in improving the quality of diabetes care. And I would like to thank you for your action.
Thank you to Professor Peter Schwartz for his message. We are happy to announce you we have already 362 participants already. We will continue with the next speaker. It is a recording from Professor Edward Boyko. He's a professor of medicine and epidemiology of Washington University, and he is also a staff physician at the VA Puget Sound Healthcare System in Seattle. He is one of the two Atlas co-chairs, and he will talk about the IDF Diabetes Atlas, global, regional, and national prevalence estimates for 2024 and projections for 2050.
I want to thank the organizers of this session for inviting me to give this talk on key findings of the IDF Diabetes Atlas 11th edition. So let me just first give everyone information about the history of the IDF Atlas. Currently we're in our 11th edition, and the Atlas first was produced in 2000, and here are the covers of all the Atlas editions since 2000. So a 25-year history. Let me just first give you an overview of the Atlas methodology. 246 data sources from 153 countries were selected to estimate diabetes prevalence for the current IDF Atlas for 215 countries or territories. The data sources come from countries which comprise over 93% of the global population. In the 62 countries lacking in-country data, estimates were extrapolated using diabetes prevalence data from countries that are similar in ethnicity, language, World Bank income classification, and geographic location. Future projections have been calculated using the United Nations population predictions and degree of urbanization. These predictions only take into account changes in the distribution of age, sex, and urban-rural residence ratio. We do not try to predict how diabetes prevalence will change over time because that would be guesswork. So who does the work to produce the IDF Atlas 11th edition? Well, there are two co-chairs. My co-chair is Diana Magliano from Australia. There are 17 special interest group leads. There are about 100 worldwide experts. And then there's an editorial team of 6 persons. So what are the estimates from each Atlas edition from 2000 to 2024? Well, starting in 2000, the worldwide prevalence, the worldwide number of persons with diabetes was estimated to be 151 million. And over the years, that number steadily increased until in 2024, the number is 589 million. So that's a 400% increase over that 24-year period. Note that the world population has only increased about 33% over that same time period. So there's an inordinate increase in diabetes compared to the world population increase. So here are some highlights. So we estimate in the 11th edition that 1 in 9 adults between the ages of 20 to 79 years has diabetes, so 589 million people. About 1 in 8 to 1 in 11 have intermediate hyperglycemia, either impaired glucose tolerance or impaired fasting glucose. About 1 in 4 adults over age 65 years has diabetes, so the prevalence is extremely high in elderly people. 4 in 10 adults with diabetes are undiagnosed, so about 252 million people worldwide do not know they have diabetes. About 1 in 5 live births are affected by hyperglycemia in pregnancy, and in most cases this is due to gestational diabetes mellitus. About 12% of global health expenditure is spent on diabetes, which comes to about $1 trillion. 3 in 4 adults with diabetes live in low and middle income countries. There are about 1.8 million children and adolescents below 20 years of age who have type 1 diabetes, and 3.4 million deaths were attributed to diabetes in 2024. So I gave you information about 2024. Now what about 2050? So in 2050, we expect that about 853 million persons worldwide will have diabetes. This is about a 45% increase. And shown here are the 7 IDF regions color-coded. The greatest increase proportionally is expected to be in Africa, where we expect a 142% increase, followed by Middle East and North Africa. And then Southeast Asia, which is mainly the population of India. The lowest increases in diabetes prevalence and diabetes number will be in the European region and the Western Pacific region by 2050. So where are the highest numbers of adults with diabetes by country? Well, the darker the red, the higher the number. And you can see here that, of course, not surprisingly, the most populous countries have the greatest number of persons with diabetes: China, India, Pakistan, Indonesia, and also the United States. The prevalence of diabetes increases with age. Note that before age 30, less than 5% of individuals worldwide have diabetes, but this increases dramatically with aging, especially in low and middle income countries, where by age 70, about 1/4 or 25% of individuals have diabetes. So there's a big difference in diabetes numbers in persons living in urban and rural areas, with greater numbers of persons with diabetes in the urban areas. Shown here are the numbers of persons with diabetes in urban versus rural areas in 2024. In 2050, we expect the number of persons with diabetes to increase substantially in urban areas without much change in the number of persons with diabetes in the rural areas. Where most individuals with undiagnosed diabetes worldwide? Well, the highest proportion of persons with undiagnosed diabetes is found in the African region. The line shows the number, the greatest number, and that's in Western Pacific and Southeast Asia, probably because these are the most populous countries in the world. So shown here are the proportions of adults with undiagnosed diabetes, and the red colors, the darker the red, the higher the proportion with undiagnosed diabetes, mainly African countries, also some countries such as Kazakhstan, Mongolia, and Indonesia. What about hyperglycemia in pregnancy? Well, this is most common in Southeast Asia, which has the highest number of births affected by hyperglycemia in pregnancy, and also it has the highest age-adjusted prevalence of hyperglycemia in pregnancy, over 30%. With regard to type 1 diabetes, the light blue bars indicate the number of people with type 1 diabetes, and you can see here that the European region, followed by the North American Caribbean region, have the highest number of persons with type 1 diabetes. The age groups less than 20 years, 20 to 59 years, and greater than or equal to 60 years of age are shown here. And you can see most of the type 1 diabetes patients are in the middle age categories. And the smallest number of type 1 diabetes patients is in Africa. So in summary, the IDF edition of the Atlas, the 11th edition, estimates that 1 in 9 people aged 20 to 79 have diabetes. This equates to 589 million people in the world. By 2050, this number will increase to 853 million. There still remain gaps in our estimates due to absent and low quality data in some parts of the world. There is a strong need for effective intervention strategies and policies to stall the increase in the number of people developing diabetes. So I mentioned all the individuals involved in producing the Atlas, and here they are all named. And if you obtain a download of the Atlas, you can review each and identify everyone on this list if you so choose. And to download the Atlas, scan this QR code to obtain a free Atlas download. Thank you for your attention.
We thank Professor Edward Boyko for his interesting presentation on the key findings from the latest IDF Diabetes Atlas 11th edition. And now we will proceed with an IDF Diabetes Atlas demo, how to find the data you need. I will start first. Professor Boyko already mentioned that the IDF Atlas is a long-standing project. There is more than 20 years of IDF Diabetes Atlas estimates. Is an authoritative and valuable academic and advocacy tool, providing the latest data on diabetes impact. And all this is freely available online. What type of diabetes atlas data estimates are included in this project? So we have diabetes estimates by country, region, and global. We have diabetes-related mortality numbers, diabetes-related healthcare expenditure, diabetes in older adults in this specific edition of the Atlas. We have data on undiagnosed diabetes, intermediate stage of hyperglycemia, and that includes impaired glucose tolerance and impaired fasting glucose, hyperglycemia in pregnancy, and in the latest edition of the IDF Diabetes Atlas, we included specific diabetes complications such as dementia, cardiovascular disease and diabetes, and diabetes-related retinopathy. the resources that they are available in the IDF Diabetes Atlas website is the printable version of the latest IDF Diabetes Atlas 11th edition, a direct access in the data through the online data portal. My colleague Irini will present you a live demo how to use this data portal. Fact sheets that can be downloaded on global and regional data, a PowerPoint presentation that includes the slides that Professor Boyko just presented to you. You can download those slides and use them for your own activities. Podcasts and webinars, the data sources, the surveys that were used to calculate our estimates are available in our website. And if you're interested to delve further into the methodology, you can download the publications related to the IDF Diabetes Atlas. And here is the QR code that you can scan to access the website. So I will start right now with a demo of our website. I will share my screen and show you how you can find all the data in the IDF. One second. I will show you how to find all the resources in the website. So you can see the website here, the IDF Diabetes Atlas website. The address is diabetesatlas.org, and this is the front page, the home page of the website. Directly when you enter the website, you can see the menu bar and the data portal. So you have direct access in the actual data of the Atlas. I won't go further into that right now because my colleague Irini will explain you how to use it and how to find the data. I will just do an orientation of the website and how to find our resources. So when you access our website, you can directly download from the top blue button the Diabetes Atlas printable version. It's freely available online. The only information you have to provide is your email, affiliation, and this is for communication, for further communication. And then you can move further down on the website in order to discover key messages from the latest Diabetes Atlas edition, a video with the key findings. I invite you to view it and access it, and feature resources such as fact sheets, podcasts, and reports. But more in detail, if you go back up in the main bar of the website, you can have not only the direct access in the data through the website, but through the main bar, data by location or data by indicators. Again, I won't go further there because my colleague, she will show you, Irini Yenizaridis, how to access the data. But I want to go to resources and a little bit describe you what is available for the Atlas users. As in the top of the website, we have the IDF Diabetes Atlas, the latest, for download, free download on your computer. Besides that, besides the printable version, we also have fact sheets on global and regional findings. So you can access and see diabetes around the world and diabetes per region, Africa, Europe, Middle East. Just to give you an example, simple, you download it, you see here, it goes on your computer. If I open it, you have the fact sheet. This is very useful if you're interested in a specific region, because for example, for every region, like here in Africa, you have prevalence in all the countries in Africa region, key messages, all the indicators for this region, top 5 countries for diabetes prevalence and number of people of diabetes, and also an analytical table with all the diabetes estimates of the Atlas for every country in that region. That's another feature that I invite you to explore for the Diabetes Atlas. If you go back to the website, to the resources, besides the fact sheets, we have the Atlas presentation. This is a very useful slide deck with key findings from the Atlas. Many of them were presented by Professor Boyko right before me today. And you have fact sheets, Atlas presentation slides, and additional resources, which includes our selected studies. You can explore all the studies that we used on our analysis, how to cite the Atlas. If you use Diabetes Atlas data, how to cite. But I want to go to additional resources such as podcasts. You can find all the Atlas-related podcasts here. You can download the latest 11th edition, which is very interesting. We have the 2 Atlas chairs presenting the key findings from the Atlas edition. Scientific papers and posters if you want to delve into further into our methodology. And closing, I want to say that you can still find all our previous Atlas editions in case you want to go back into previous year's estimates. From the 10th edition all the way to the first edition of the Atlas, you can explore the data through our website. Like I said, everything downloaded for free. We have also Diabetes Atlas special reports for specific topics on diabetes impact, such as Diabetes Atlas and kidney disease, diabetes in indigenous people, type 1 diabetes, diabetes and COVID-19. You can explore these available topics. So right now I want to stop and move to to my colleague Irini Genitsaridis. She's the IDF Atlas data scientist. She's the best to describe how the Atlas data portal works and how to find data using our Atlas data portal. So I will welcome her now and let her share her screen and describe you the data portal. Welcome, Irini, and to you now. You are muted. You can unmute.
Okay. Hello, I'm Irini Genitsaridis. Today we are going to show you how you can find Atlas data. In the website, we have an open access freely available diabetes data portal. So apart from downloading the Atlas book and the presentation at the fact sheets, you can also directly access the data in the website. So now you can see our website. And in the website, you can immediately see the interactive map. And in that interactive map, you can select a particular region or a specific data by country. And another way to access the data is going into the menu bar and clicking data by location. And here you can see that you can select different regions, Africa, Europe, Middle East, and all the other regions. And additionally, you can select to access the data by category. So for example, let's say we are interested in impaired glucose tolerance. And we are selected to see the data for this specific indicator. Here you can see the key messages. And you can also view the interactive map that has data across the world for this indicator. And for all our graphs and maps, you can download the data as JPG, PNG, or CSV format. If you go further down, you can see the data specifically for impaired glucose tolerance for all the regions, and after that, for all the countries. We have available data not only from Atlas 11th edition, which is 2024, but we also provide data for our projections for 2050 and data from previous editions for 2011 and 2000 to make comparisons. This is how you can explore the data if you are interested in a specific indicator. Now let's go back and let's say you are interested in a specific location, either a region or a country. If I go back to the main page, I will give you an example on the data for a specific country, let's say United States. So I clicked on United States on the map, and once you click on the specific country, you can immediately see the number of people with diabetes for this country. And like I previously said, data are available from this Atlas 11th edition for 2024, and also for our projections 2050, and for 2011 and 2000 to make comparisons. You can also find the resources that were used to calculate these estimates. And then you can find also graphs that they show the people with diabetes in thousands, so that you can see the trend and also for age standardized prevalence of diabetes. Not only you can observe the trend in this country, but you can also compare with another country by selecting, for example, in this drop-down list, a second country. Let's say we select Canada. And you can compare up to 3 countries in the graphs. Here, for example, you can see that the number of people with diabetes is much higher in the United States compared to Canada. You can make the same comparison for age standardized prevalence. In all the graphs, as I said, you can download the data in different formats, such as CSV, PNG, and JPG. And then if you scroll down further for the specific country, in this case, United States, it can be any country from the 215 that we have in the Atlas. You can see the data for all the indicators, diabetes estimates, impaired fasting glucose, impaired glucose tolerance, mortality, hyperglycemia in pregnancy. All the data points for all the indicators for the specific country. For the 11th edition 2024, for the projections of 2050, and for 2011 and 2000 to make comparisons. Thank you very much, and we can continue now to the next speaker.
Thank you very much, Irini. We will have the chance to address questions and have further discussion with the co-panelists. I want to move now to our next topic, the advocates' experience using the IDF Diabetes Atlas. And I would like to start with Ms. Lucia Feito Alonca. She's a member of the IDF Blue Circle Voices from Argentina and Spain. Welcome, Lucia, and looking forward to hear your presentation.
Thank you so much, Paraskevi. So, did you know that 1 in 9 adults worldwide live with diabetes, and millions of them don't even know it? Hello, everyone. My name is Lucia Feito. I'm a Blue Circle Voice advocate for people living with diabetes. And today, I'd like to share with you how I've used the IDF Diabetes Atlas as a tool in advocacy. I've personally used the Diabetes Atlas to create a deck on the global diabetes ecosystem in the context of my work as a consultant for a global diabetes NGO, and to develop content for social media channels and advocacy campaigns. But more than that, I want to show how you can use it too, to make your voice stronger, to build better campaigns, and to advocate with evidence. Next slide, please. Let's begin with something basic. Why data matters in advocacy? Because stories move hearts, but data moves decisions. When we speak from personal experience, we connect with people, and that's what we do as advocates often. But when we add trusted numbers, we can influence policy, funding, and public awareness. That's why advocacy should be data-driven, and the IDF Diabetes Atlas is one of our best tools. For example, in Spain, about 4.5 million adults live with diabetes, around 14% of the total population. In Argentina, the situation is very similar, around 4.3 million adults, with one of the highest prevalence rates in South America. But here's the alarming part. It's estimated that around 30% of people with diabetes in Argentina and about 35% in Spain don't even know that they have it. That's millions of people living without diagnosis or treatment. And what does this mean? This means that data matters because it turns invisible problems into visible priorities, because these people don't have a diagnosis or treatment, often until complications appear. Next slide, please. So how do I use the Atlas, and how can you use it? Let me show you three main ways. The first one is understand the global picture. The second one is identifying your advocacy priorities. And the third one is creating powerful messages. In the first section, the IDF Diabetes Atlas reports that in 2024, approximately 589 million adults were living with diabetes in the world. This represents about 1 in 9 adults globally. By 2050, this number is projected to rise to 852 million. The Atlas also highlights the regional differences. Pay attention to the fact sheets that were earlier mentioned, as they can help us obtain specific data about that region. For example, in Africa, diabetes prevalence is relatively low at around 4.2%, but over half of the people with diabetes remain undiagnosed. In North America and the Caribbean, the prevalence is much higher at about 15%, and healthcare spending per person with diabetes often exceed $9,000 annually. It is the region with the highest expenditure. These contrasting figures help tailor advocacy efforts to the specific needs and contexts of the different regions. In the second section, identifying our advocacy priorities, the Atlas reveals that in low and middle income countries, around 3 out of 4 people with diabetes live with limited resources. Many lack regular access to essential diabetes care, including insulin, self-monitoring tools, and diabetes education. Using this data when engaging with policymakers highlights the critical gaps in diagnosis, access to treatment, and affordability. Because the data is published by the IDF, it carries strong credibility that supports effectively advocacy. And then with all this data, we can create powerful messages and calls to action. Next slide, please. Advocacy is not only about passion. It surely is full of passion, and we advocates do advocate with all our hearts. But we also need to create an impact. And to achieve this, we must combine storytelling with solid data. The IDF Diabetes Atlas empowers us to turn lived experience into evidence-based advocacy. I encourage you to approach the Atlas as a very strategic resource. Begin with your country and region. Review the most up-to-date data. Identify critical gaps. translate then insights into clear messaging, concrete actions, and policy recommendations. Finally, I would like to make a suggestion because I believe in the power of combining patient-reported outcomes. So what people report about living with diabetes and their issues with access, for example, with this epidemiological and that data that is already available. It could be a very good combination because it would give us more insight into what people with diabetes are experiencing firsthand in that place. This would strengthen advocacy efforts and help create more effective policies and treatments to improve care globally. Because when we combine human stories with trusted data, we just raise awareness and change. Thank you.
Thank you, Lucia, very much for your presentation. I'm happy to see the live use of the IDF Diabetes Atlas. Now we will move to our next speaker for this part of the conversation, the advocate's experience using the IDF Diabetes Atlas, is Ravi Subramanian. He is also a member of the IDF Blue Circle Voices from Australia. Unfortunately, he was planned to add his input live today, but because of storms that are taking place in South Australia, he has connection problems. But luckily, we have a recording from him, so we can hear his input and his personal experience.
I am an Australian citizen of Indian origin and live in Adelaide. As a type 2 diabetic patient, the IDF Diabetes Atlas is a valuable resource providing for me insights into the global impact of the disease, prevalence data, and information on managing diabetes. It helped me understand the bigger picture of diabetes, helped me understand about potential complications, and aided me in finding resources for better management. The IDF Diabetes Atlas primarily aids diabetic patients by providing evidence-based information on the global prevalence and impact of diabetes, including statistics on morbidity, mortality, and health expenditures. It also offers insights into pathophysiology, classification, and diagnostic criteria for diabetes, as well as guidance on prevention and management strategies, including those for specific populations like indigenous people and children. Furthermore, it highlights the importance of early detection and treatment of complications like kidney and heart disease. The IDF Diabetes Atlas empowered me by showing that I am not alone. While the IDF Diabetes Atlas is not a direct treatment tool, it helps me by helping me understand the interconnectedness of issues, helping me understand identifying the root causes, and helping me develop solutions that address the underlying systems that perpetuate problems, and by providing strategies to prevent complications and promote health equity. While studying for my Bachelor of Health Science at the University of South Australia, my research topic was diabetes. One of my searches in the online library brought up the Diabetes Atlas. It was an amazing search result for me, for that was when I came to know about the organization called International Diabetes Federation. My university confirmed that I could cite the atlas in my literature review sections, especially when establishing the background and significance of my study. Quoting from the IDF Diabetes Atlas enhanced the credibility of my research by grounding it in peer-reviewed and globally accepted data. Helped me in comparing diabetes prevalence in low-income versus high-income countries to assess the role of economic factors. The atlas helped me identifying research gaps. The atlas includes charts, graphs, and maps that were used with appropriate citation in my thesis, presentations, and posters. The atlas includes data on diabetes-related healthcare costs, economic burden, and policy responses. This supported my policy-oriented research. The atlas helped me understand how data is collected, and analyzed, and in understanding epidemiological methodologies for improving my own study designs. The IDF Diabetes Atlas is a valuable research tool that provides essential information on the estimated and projected global prevalence of diabetes. Every edition of the IDF Diabetes Atlas includes more quality data from more countries, thereby providing an increasingly accurate description of the global diabetes landscape. For me as a research student, the IDF Diabetes Atlas provided me with reliable and current data, global statistics, age and gender breakdown, and trends over time. The atlas helped me increase my public and political awareness and enabled me to frame health policies that support diabetic individuals. The IDF Diabetes Atlas is a cornerstone for my diabetes advocacy, equipping me with evidence, tools, and credibility needed to drive change in policy, funding, public awareness, and global health strategies. The IDF Diabetes Atlas provided me with up-to-date statistics on diabetes prevalence, mortality, healthcare expenditure, and undiagnosed cases across countries and regions. I used this data to highlight the scale and urgency of the diabetes burden. The Atlas is a key resource for my World Diabetes Day campaigns and other awareness initiatives to inform and educate public and other important stakeholders.
Now with Lucia and Irini. And first, we're happy to proceed with some questions from Lucia.
Hello again. Well,
So with Irini, we are happy to take your questions. And maybe I think Ravi was thoughtful and gave you some of his in case he cannot join. So we can have his aspect as well.
Okay, my first question is for Irini. And so, Irini, could you explain what data science means in a simple form, in simple terms for a general audience, and how it is connected to diabetes and the IDF Diabetes Atlas?
Yes, of course. So basically, Atlas is a systematic collection of studies across the world, and the data most of the time are not harmonized. They have heterogeneity. They report prevalence in different age groups, for example. So we use data science to harmonize the data, to be able to make inferences and derive conclusions. Sometimes we also have missing data, or we want to do projections. We want to predict future information. Those are also cases that we use data science for. Thank you.
Yes, and one more question that is related to this one, really. Is there any aspect of data science or big data that advocates should be aware of to strengthen our communication and advocacy efforts?
Yes, I think we should be careful of how we interpret the data, because when, for example, we have missing information for a particular country, it's something that we should report and we should emphasize, which is compared to a case of a country that we have in-country data sources, studies. So we should make a distinction between extrapolated information, countries that do not have data, but we use other countries to derive information, and countries that have their own data, more reliable data sources. That's something that advocacy should report when we provide key messages and information about the country. Thank you.
Thank you so much, Irini. That was quite helpful. I think that the big data is so important nowadays, and this includes all fields, even advocacy. And it's also important for the field of diabetes, who would have said, but it is that way. And now I have 2 questions for Paraskevi, mine. Then I will ask Ravi's questions. Ravi, we couldn't listen to his presentation, but we will play the recording afterwards. So, Paraskevi, how does epidemiology inform the development of the IDF Diabetes Atlas? And what are the main challenges you face in collecting reliable global data?
So very important question, because it's the whole back of the Atlas project. So of course, the Atlas estimates rely on epidemiological data. And when we say epidemiological data, what type of data we use in the Atlas? So when we are preparing the Atlas, we search our IDF member associations, our network. Besides that, we perform an extensive data collection for published studies, surveys, population-based surveys on the diabetes per country. For every country, we collect all available sources. That means published studies, national health surveys, WHO STEP surveys. So we are trying as much as possible to gather anything that is available per country. And here I want to invite everybody who are aware on a study on their country or a survey, and they can share that with the Atlas team. Please email us. That's very important for us of gathering all the available data. So this is where Atlas relies, where the Atlas data are relying on the published studies, surveys, medical registries. Now, very important is the good quality data. So we gather all the data available, but it's very important to score those data and make sure we use the best quality, because we want to be as accurate as possible. And besides that, another big problem is that probably you're all aware that there is not enough data on all the countries, and specifically high quality data. So unfortunately, for especially some low income countries or some countries, for example, in Africa, we don't have studies for diabetes estimates from the country. So there, what we have to do, and we are doing in the Atlas, we are extrapolating from other countries. And so that means that we take similar countries, and based on their data, we calculate that country. So that's, of course, not ideal, but that's the only solution when the data are not good quality. Yeah.
I see. And how can diabetes advocacy use epidemiological data effectively when speaking to policymakers or to the public?
So I think, and on your presentation, I think it was a great example of that, because I saw that you said 1 in 9, 1 in 8, 40% have diabetes. So that's the best way. So the data are there. We give the numbers, but I think the best way to present them and to use them in advocacy activities is to take the key messages. And usually the key messages, you understand it better than me, is when you say in obvious number, 1 in 8, 1 in 4, half of them, 1 in 2. So these are powerful messages relying into very good methodology of the Atlas. It's been there credible for 20 plus years. So I think that's the best way. And that is why today we have the demo and showing the resources, because what we do in the Atlas project is also to try to give as many resources as possible. So we have the book with the numbers, but then we're trying to give the fact sheets if you are interested per country, or the PowerPoint presentation that you can immediately use the slide from our PowerPoint for your presentation or your letter to your policy makers. So I think using key messages that they are powerful, using Atlas resources, it's a credible project and source of data. So I think that helps advocacy groups. And you are a bright example, you and Ravi. So I'm looking forward people to see your presentation afterwards as an example. Yeah.
Thank you so much. Yes, and the fact sheets are really helpful and provide with very visual and easy to grasp information that is also very useful. So I now have some questions from Ravi, who cannot be here with us. So I'm going to read the question, and then you or Irene reply depending on who do you think is the right person to reply, because it says questions for the team. So first one is, are there any disparities in diabetes outcomes or complications based on demographic characteristics like ethnicity, socioeconomic status?
So yes, there are differences, and in the Atlas, that's something that in the Atlas we pay a lot of attention. So we present the data not only by country and by region, which shows disparities or different data per region. For example, Africa has the highest undiagnosed diabetes. For example, Middle East and North Africa has the highest prevalence of diabetes. So we present the differences between regions, countries, and because we mentioned demographic, we also give differences between age groups, between male, female, and very important, between urban and rural, because urbanization is related to diabetes. We know that in countries with high urbanization, there is high percentage of diabetes due to lifestyle characteristics. So these are available in the Atlas, and I invite you to see the key messages because we put that aspect into our key messages.
Thank you so much. And a question from Ravi is, what are key risk factors associated with diabetes development? Someone also in the audience has asked if there are specific risk factors to Africa and the Middle East that explain the higher expected increase in prevalence compared to other regions.
So I will let my colleague Irene to say about the risk factors, but I know that for Africa, it is predicted to increase because we do also projections. We say how much is the diabetes in 2024, but we also project to 2050 to see how this, event will evolve. So I have to say that the reason of Africa is because it's predicted to have the highest population increase, and also lifestyle changes. The diet is changing. So although we had low proportion of diabetes, that is predicted to increase. And the urbanization, like I said, the increase of urbanization, but regions such as Europe that is already urbanized, let's say, the prediction for the future is not high because there is not going to be more urbanization in that region compared to Africa. So that is one explanation. But of course, experts might give other aspects, but I know from the Atlas that's one of the main reasons on that. But maybe, Irene, you can say what are the risk factors in general for diabetes?
For diabetes, for example, we have the modifiable risk factors such as obesity, diet, the exercise of people, and there are other risk factors that we cannot change, like age or gender. And as we told you, there are countries that we are expecting to have larger changes in terms of urbanization, and other regions like Europe that we don't expect so much change. And this is something that will drive higher rates of diabetes and a number of people with diabetes.
The projections are so important for advocacy as well, because everything is connected and we see what future is coming. So we want prevention and we want to improve things. Next one is, are there any disparities in diabetes outcomes or complications based on demographic characteristics like ethnicity or socioeconomic status?
Sorry, I think this is related to before. Yes, it is. Like I said, in countries or regions that are undergoing urbanization and changes in the diabetes risk factors such as physical activity, diet. This affects the diabetes numbers and also the complications, but also the quality of care. So we know that low-income countries have low prevalence, but it's predicted to increase. So yes, that is what we were saying for Africa as well. So indeed, we have disparities with demographic differences.
Thanks so much. And a very, very interesting question from the audience. How do we improve the quality of data in low and middle income countries? That's a good one.
That's a very important, yes. And because we keep saying we don't have data, so people say what we're supposed to do. So yes, I think what we need is good studies and good quality studies. So advocates like you, Lucia, and Ravi, and you can advocate not only for change of policies, but also for investing from countries for national health surveys. So if there is a very good national health survey from a country that we don't have data, that's the best way to gather the data and present the diabetes estimates. So advocating for national health surveys with your healthcare professional, asking for participating into diabetes registries to register the diabetes people in your country. So I think this is what will be for advocates what is needed. In general, we need countries to have national health surveys or good quality data to know the diabetes situation in their country. For example, many African countries have more than 70% of undiagnosed. 7 out of 10 people who have diabetes are not aware they have it. So this is a problem that needs to be, faced.
Thank you so much. And more questions keep coming. Question for the epidemiology team. The GDM data for the entire African continent is extrapolated from individual studies in only 6 countries. Is there a concern that there are perhaps underestimating regional heterogeneity in such a large degree of extrapolation?
I don't know, Irene, if you want to comment on that, on the studies of GDM that we use for the Atlas calculations.
I think extrapolation is something, as I said, that should be reported. We should be transparent, and we should report the exact data sources that were used to make the estimates, so that researchers could understand the reliability of the estimates. It's important to know where the data come from and how much extrapolation has been performed on the data. It's not the same in every region or in every country. There are regions that we have more quality data. Sevis told you there are quality studies that take place periodically, every 4 years. And there are other regions that the data are scant. So we try to make inferences from the data that we have, but we should be transparent about it. We should be transparent about the degree of extrapolation, the degree of missing data, how the model has derived those estimates, so that everybody is aware about the quality and the reliability of the estimates.
Another question from the audience. Have there been any changes in the methodology compared to previous editions? Are the estimates from this book directly comparable to past books?
Yes, so this is also, and when in the printable version of the Atlas, in the intro, we comment on that changes from the one edition to the next can be carefully evaluated, because that doesn't mean that maybe in one country, Germany, suddenly from 2021, last Atlas edition to this edition, the diabetes prevalence decrease or increase. We might have a new study that is better quality, so this study is more accurate, and the data change. So that doesn't mean that we should have direct comparison with previous editions, but also methodology, right, Irene? Because what we try from every edition to the next is to have to improve our methodology, the analysis, the data that we use, updated population data.
Yes, we have
updated urbanization data. You can more come into that.
In each edition, we are updating the urbanization data and population data using United Nations prospects, and we are also updating our data sources. So not exactly the same data sources are used in each edition, because if we have a new study, a more quality study, we replace our old study. And this is done in each edition. We are also estimating, for example, which are the regions that extrapolation should be performed. So in each edition, domain experts, the Atlas Committee decides on which regions should be the extrapolation regions. And they take into account not only the geographical aspects and the income aspects of the countries, but also the available studies. So, for example, we cannot just say we will extrapolate from a specific region if we have only one study from this region. So we are trying to balance between the availability of data sources and also the characteristics of the countries to make inferences. So, yeah.
Thank you so much. And a very interesting question from our colleagues at T1 International attending this webinar. With that in mind, is there any plan for IDF to expand its data collection efforts to include more representative self-reported data on out-of-pocket expenses and access to care? We feel that this could add even greater depth and urgency to advocacy efforts, particularly around affordability and equity. This is essential because for people living with type 1 diabetes, insulin is not optional, and accessing it is our life. Our life is on the line.
I agree, and I think it's been a couple of years. I think 2016, if I remember correct, it was the last time that IDF released something on the access to medicines and affordability. And I think there is a lot of discussions only within the Atlas project, but within IDF, that as IDF we should have an extensive research into that and release something. We are preparing right now, we are setting down the topics for the next edition. So like Irini said, there is a committee of experts around the world on epidemiology and diabetes. So they evaluate the quality of data and whether there is enough data to present, estimates and numbers around the world. Like I said, you see, even for diabetes, estimates how many extrapolations we have to do and how many guessings. And so imagine for types of diabetes or for issues that they are not well reported around the world. But regarding the affordability and access, I have to say that IDF is very interesting into that. And I think we are looking into producing something coming up. I cannot say yet about the 12th edition. The topics have not been decided. But I have to say that IDF is well aware of that topic and issue.
That's amazing. And I think that in co-creating with people with lived experience of diabetes would enrich greatly the data shown, because they will also show what's missing and what's needed. Something that the bare numbers cannot show. So it could be a way of enriching and integrating, in my opinion. We have another question. Is there a separate detailed data on the over 65 years old group showing the trend over the years in the current IDF report?
Yes, so in this IDF Atlas edition, I think the last time that Atlas had data on people over than 65 was in 2019. So in this edition of the Atlas, we have data on people over 65. You can find them on the website and also on the printable version. We know that that group has a high proportion of diabetes, so it's of a great interest. So I invite you to download the Atlas and also visit the data portal to discover the estimates for people over than 65 from this edition.
Yes, thanks so much. We are receiving so many questions. So I will read a couple more because we are being flooded with questions. It seems that this webinar has been very successful. So here goes the next one. It seems that data contributors are mainly academic institutions and public sector. What about the inclusion data from private sector? Is IDF considering it?
So we don't have a specific preferences for academic. Like I said, our preferences and quality of data is on published data. So if data are published and are population-based, so usually we accept them. Regarding efforts, I know that we also support as IDF the ICARME registry, which is a registry on diabetes and cardiorenal complications. So maybe in the future we will consider this data or this data when they are published. So there is no preference on the source of evidence. If they're published on a peer-reviewed article, usually they are reviewed by the Atlas, or if they are provided by us. Again, if there is data from private sector, we invite people to share with us. Usually when we start, and this will happen soon, a new Atlas edition data collection, we put a call for data on journals, so people are aware that we're looking for new data for the Atlas and they can share their studies with us. But I can use the visibility of this online event and say, please share with us data that you have available. And yeah, this is enhances, the efforts to collect whatever is available out there.
Completely. Another question is, there is no information related to the percentage of each pharmacotherapy usage in the type 2 diabetes population. Perhaps the IDF would consider including this issue on the IDF Atlas in the future?
It's good to have suggestions on topics, I agree, because every Atlas has a core part, which is the estimates of diabetes per country, per region, then healthcare expenditure, mortality, other types of diabetes. And there is always a chapter that can be a specific topic that the Atlas is looking into. In this edition, I mentioned was some complications, dementia, CVD, and retinopathy, but we're always looking for new topics, and pharmacotherapy use in type 2 diabetes population is something that, like I said, I can use and discuss with the Atlas committee and see what the data are available, and if there is enough data available, epidemiological data, to make a report on country level or at least on regional level, then yeah, I think it's of good interest, and welcome for suggestions. Please also feel free to communicate with the Atlas team.
Amazing. Well, now comes a challenging question. The Lancet Commission's estimated that diabetes prevalence in Sub-Saharan Africa was much higher, near to 8% a few years ago. IDF estimates that they are much lower. Can you explain why?
So I have to go in specific the methodology, but I have to say that yes, there is differences between estimates and methodologies. I think there was a recent NCD risk factor publication that had higher number than that IDF Atlas. I think it always depends on the methodology that is used, and there can always be differences and different decisions in the methodology that can affect the level of data. For example, if two diagnostic criteria are used, or one, if it's HbA1c used as a diagnosis, or FPG, fasting plasma glucose, can affect the decisions. Definitely, it's good to be a consortium and agreement between different teams, so we have consistency between numbers. And I think IDF works towards that. We have a collaboration with the Global Burden of Disease, another database, and we're trying to compare our methodologies. So I think that's the best way to try to collaborate and see what are the differences. But small methodological differences can lead to different estimates. So
to add to what Evie said, for example, IDF distinguish between prevalence in urban and rural settings. That's something that other teams or other models may not consider, distinguish between the urban and rural setting prevalences that have different estimates. So the factors that we use in a model can drive different results. The data sources, if they are different, they can provide different results. And it's important to compare our methodologies to see what are the factors that drive changes, and especially so large changes between two models, and report them and be transparent about it. To identify both our strong points in its team and in its model, and our limitations. So yes, we would like to make a comparison between the density risk model and our model to see what is the exact factors that drive these changes, and understand them, and have more reliable results in both models.
Okay.
As an advocate, also in advocacy point of view, we can all agree that no matter the differences, we are all the numbers of diabetes are high and rapidly increasing. So that's something that is agreed by all. So
Undeniable.
and this is an unfortunate fact, but is a strong advocacy message.
Completely, and a call for action to start working on this pressing issue for sure. So here goes the next question. One frequently asked question is about using estimates versus real data. What is IDF doing to get data where it is lacking?
To use data when they're lacking?
When it is lacking. When there is no data.
I think, Irini, you can describe
Yes,
the extrapolation, like we're saying.
It's related to the question about how we extrapolate. We have an Atlas committee that decides on which regions have both enough data, and they are similar in terms of geography, economy, ethnicity, so that we use studies from those regions if a country lacks data. That's how extrapolation is done in IDF. Of course, we can always improve our methodology, and in each Atlas edition, we have to incorporate improvements that will lead us to more reliable results.
Well, here comes another question that is also very interesting, and it is from one of the IDF Lebanese members, to whom we report if actual number of Taiwan patients is higher than the estimated one in the Atlas. This could be interesting to compare evolution before and after a humanitarian emergency.
So if the data are different, or your comments, because the IDF Atlas team is happy to receive your comments and discuss them with the Atlas committee as well. So you can always send your message to info@atlas.org is the email of the Atlas team. You can also find it in our website. So we're always happy to receive the comments, and we always take every comment that we receive on our inbox into consideration, I have to say. I can guarantee that. Okay,
and well, we have to be moving to closing because there have been so many questions, more than 50. But I would like to finish with one more, and it is regarding Taiwan diabetes in Africa. Is there a reason why there's such a low prevalence compared with other regions?
So I think the low prevalence, I think experts can reply better into that than us. But I think it's accepted that due to the diet and the urbanization levels that we said before, and modifiable risk factors, that they are lower in Africa. There is more physical activity, there is better diet. So I think this can be an explanation, and that's why it is projected to increase much more than any other region to 2050.
Do we have anything about TB in the Atlas? I guess TB.
No, we don't, and we have that into consideration to be included in the future. We had it in an old edition. I think we had it in the 7th edition, if I remember correct. But TB and diabetes are related, and it's one of the topics that it's under consideration. So yes, it's always, like I said, welcome to send your suggestion. But like you said, Lucia, I think unfortunately we have to close. We had more than 520 participants, I think, at some point, and more than 80 questions. But I think it's time to go to closing remarks. And thank you very much, Lucia and Irini, to be with us today. The recording, slides, and feedback questionnaire will be sent to all registrants in a few days. Please respond to the feedback questionnaire to help us improve future IDF online events. And send us any questions, like I just said, new studies you have in mind, new topics, questions about the methodology or disputes on the numbers, to atlas@idf.org. Thank you very much for being here today with us.